Thank you very much, and what an inspiring presentation, Todd. Just fabulous to hear, and quite a hard act to follow. But I'd like to also start by paying my respects to elders past, present and emerging, and recognising that our First Nations people were indeed our first scientists, our first nutritionists. So thank you very much for the opportunity to come and present today about my passion area, which is nutrition in the first 2,000 days. And I'm particularly interested in that segue between research and practice. So I spent the first 10 years of my career working as a dietitian in community health and a whole range of population health roles in policy and in practice. And I very much bring that practitioner lens to my research, and I'm only interested in research that can actually make a difference on the ground. Sorry, still trying to work out the remote control here. So I guess in terms of prevention, we all know that prevention is an important place to think about health, but in particular prevention in the first 2,000 days. If we're going to pick a life stage, the first 2,000 days is where we can have more effect than any other stage of life. And that's because we know that those health behaviours that are formed in that first 2,000 days also track into middle childhood, later childhood, and into later life. So getting those behaviours established in those first 2,000 days is critical, particularly around reducing health inequalities. We know that those inequalities start very early in life, and they continue and in fact get wider as children get older. We know that focusing on prevention and supporting families in that first 2,000 days is very much where the public wants us to spend time and energy, and economically it makes an enormous amount of sense. So recent economic analysis suggests that for every dollar that we spend on prevention in those first 2,000 days yields $13 in return. Specifically looking at nutrition, we know that over half of women enter pregnancy already experiencing overweight and obesity. 35% of babies are breastfed through the recommended guidelines of exclusive breastfeeding for 6 months. Quite shockingly, about 22% of infants get most of their solid food from commercial pouches, which we know are very high in sugar, as well as not providing recommended amounts of iron and experiences with food. 30% of energy of our 2 to 3 year olds comes from discretionary foods. And we've got over half of our 2 to 3 year olds exceeding intakes of free sugars. And not surprisingly, about 1 in 4 children enter school already experiencing overweight and obesity. So that's not an all-inspiring picture of nutrition in the first 2,000 days. And we've got some research from our own research group that suggests that at 9 months of age, babies, about 96% of them are meeting recommendations for vegetables, which is the blue bars. But by 1.5, that drops to 3%, and it doesn't get much better at 2 years and 3.5 years. In comparison, the percentage of children that are meeting recommendations for discretionary food is low right from the beginning, right from 9 months right up to 3.5 years of age. So we've got quite a bit of work to do in this space. As I've mentioned, the first 2,000 days is an ideal window for prevention, so most women through pregnancy and postpartum are seeking that support around nutrition, both for themselves and for their children. And we've done some recent research with fathers that also suggests that they want to play a really big role with their children in this space, but they feel like services and programs leave them out. Australian researchers have really led the world in this space in developing effective interventions in this first 2,000 days. And our own research group, Professor Karen Campbell and Kylie Hesketh, developed a program called Infant, which I'm going to talk a little bit more about. And that was one of the first studies worldwide that showed that if you actually intervened and supported parents early in life, that you could actually change the trajectory of child diet and screen time over an extended period of time, well beyond the end of that support period. So So just a little bit about what is infant for those that haven't heard about infant. I know we've got a number of people in the room that are implementing the program in their communities within NEPHU. But infant is based on the concept of anticipatory guidance, so actually supporting parents with information before they actually need it. So it starts from 3 months of age, and it consists of 4 group sessions for parents where they're actually interacting and being supported by other parents. And this is complemented with a mobile phone app to provide that support in between sessions. And you can see there a comment from parents about the fact that parents do have a lot of information at their fingertips from Google and all sorts of places, but they really struggle to actually decipher good quality information and what is actually credible. Just to give you an overview of some of the key messages that are part of infant. So they focus on some of our core messages around fruit and veg and tapping into water, as well as our screen time messages of often running, as well as some of our parenting messages around role modelling of eating together, playing together, and parents provide, kids decide. So infant represents 15 years of research and collaboration between research and practice. So it started with a randomised controlled trial back in 2008, so quite some time ago, and I'm going to talk to you very briefly around the results of those trials. From there, we did some small-scale translation of infant as part of Healthy Together Victoria, which many of you will remember, back in 2012. And we've had the opportunity in 2020 to go to a statewide implementation of the program, and I'll talk a little bit more about that at the moment. So in terms of the randomised controlled trial, the trial showed long-term benefits for children beyond the outcomes of the initial intervention. So at 3.5 years, we were able to show that children who took part, or parents who took part in the intervention, their children showed improvements in a whole range of dietary measures shown on the screen there, as well as a reduction in screen time. Interestingly, at 5 years of age, so the intervention finished when kids were 18 months old. Nothing else happened from 18 months old onwards, but we were able to see a sustained impact of the intervention on a number of behaviours. And we very rarely see this with any kinds of interventions. We typically see that at the end of the intervention, things tend to start to track in the wrong direction, but we actually saw the opposite here, where those behaviours were actually maintained at 5 years of age. And just to put this into a health economic perspective, when you actually look at the impact of infant on discretionary food intake, we saw that at 18 months of age, we saw a 0.6 reduction in discretionary food serves per week. Now that sounds tiny. At a population health level, we know that that has a huge impact. Interestingly, we saw that by 3.5 years, that had gone up to 1 serve, remembering that there was no further intervention. And by 5 years, it actually had increased to 1.7 serves. So again, I guess it reinforces that concept that if you intervene early, you actually get that impact happening over a longer period of time. From a health economics perspective, you can see the numbers there, that 1 serve reduction in discretionary foods per week has an enormous impact on chronic disease prevention later in life, and huge healthcare costs, savings of 1.2 billion. The impacts on health service usage were apparent also in the short term. So we found that parents who used the My Baby Now app, we saw decreases in their usage of maternal and child health lines, GPs and paediatricians in that first 9 months of life. So we know that if we can actually support parents with that first line information, help to answer their questions, and also deal with some anxieties that they may have around feeding and growth, we can actually have health service usage savings as well. And if you apply that across the population, just alone in terms of GPs and paediatricians, that's 6.9 million. We've had maternal and child health nurses also tell us that when their parents attend infant group sessions, that when they come to their CAS visits, their key age and stage visits, they're much less anxious, they feel much more supported, and they can spend time having conversations about other aspects of child development. As I mentioned, in 2020, we were very fortunate to be funded through the NHMRC to scale up infant across Victoria. And we had a number of practice and policy partners, and this very much has been a partnership approach. We are now very interested in understanding how to support the uptake of infant across communities. So we're not only interested in what impact that we have for families when the intervention is scaled up in real world practice, but importantly who we actually reach. That's really critical. And we're also interested in the health service delivery aspects and what influences adoption and implementation, and importantly, maintenance. So there's one thing to get a program up and going, but actually to get it maintained and sustained and embedded is a completely different proposition. So infant is a priority action within the Healthy Kids, Healthy Futures program. And we've very much taken, in partnership with our practice and policy partners, a systems-based approach to integrating infant into service delivery. So while the group sessions focus on parents and infants, we've done a lot of work with practitioners around how to embed some of those key messages into their interactions with parents, whether that's through CAS visits or other interactions that they might have with parents in a whole range of different settings. And we've also looked at how we can embed some of those key messages and infant into policies and programs at the local level. So we've had 46 out of 79, so that's 58% of all LGAs implementing infant, which is an incredible achievement across the COVID years in particular. Just to give you a few maps of implementation across different local government areas. So the teal is LGAs that are implementing infant. And I understand within NEPHU we've got 10 out of 12 LGAs implementing infant, which is fantastic. The yellow are those areas that were in discussion around implementation, and in orange are those who are actually actively preparing an implementation plan. We've got a number of areas that are very interested but just don't have capacity at the moment to implement. Just to show you the map across Victoria, you can also see that we've had really great uptake across a whole range of regional areas as well. Just to provide you with a little bit more information around the practitioner training component that I mentioned. So that's self-paced and online, and it takes around 6 to 8 hours to complete over 8 weeks. And we've purposely delivered it online so that we can have equitable access for practitioners across a whole range of areas. You don't need to travel. You can fit it in between consultations, so it's very flexible to participate. And we've had over 1,300 health professionals trained to date across Victoria, including about 2/3 of all maternal and child health nurses, which is fantastic. For those of you in the room who are interested in doing the training or have staff that are interested in doing the training, it's still open at the moment. There's a current course running, and I can flick on a QR code later on just to give you a little bit more information about how to sign up for that. But in terms of following up the impact of training alone with practitioners, we found that at 12 and 24 months, that practitioners who do the training have increased confidence to discuss those key messages with parents, so that's really critical. And we've also seen some changes in practice, so in particular how frequently they have those conversations with parents, so that's changing as well. Those who do the training often do it for professional development purposes, but if you're doing it for implementing infant, there's a whole range of resources that come along with the training, including implementation manuals and facilitator guides. We've also got a whole range of resources for parents. They're accessible on our infant website. You can jump on. We've got some easy English resources, which are very high pictorial resources for parents. They're available in English, and with partnerships with Western Public Health Unit, we've been able to translate those resources into 6 languages, which is fantastic. So the language is there on the screen. We've also got full videos for parents, and they've also been translated into those 6 community languages. We were very excited to be able to launch those in-language resources with the Health Minister back in February with our NEPHU partners, and we had a lot of great feedback, and we've had an enormous uptake of those resources already, despite the fact they've only been available for a very short period of time. We're proud to say that infant has been recognised internationally by a review from the Centre for Disease Control in the US that identified infant as the strongest model for implementing a complementary feeding intervention within the community. So that's been a fantastic endorsement for infant. And we've also had endorsement from the National Cancer Institute as one of their recommended evidence-based programs for prevention of cancer in the US. One of our key focus areas going forward is around priority populations, particularly how do we reach these populations, but also how do we create interventions that are culturally appropriate and suited to these populations. So we've been doing a lot of work in this space. We're working very closely with VATCHO as one of our key partners. We have an Indigenous PhD student, Fiona Mitchell, who's working on the ground with families and community to identify appropriate early life and active play strategies for those families. As I've mentioned, we've worked closely with NEPHU and also with NEPHU around culturally and linguistically diverse populations, and indeed not only what's appropriate but also importantly how do we reach those populations with programs like infants. As I've mentioned, we've had a focus on dads as well and trying to understand how we can best engage dads as co-parents and not just that focus on maternal. So in summary, the first 2,000 days, as I've mentioned, are critical for establishing those health behaviours that have lifelong health impacts. We know that makes economic sense, and we know that that's something that parents and public really support. We know it's incredibly important for reducing inequalities in health right across the life course, and we know that we need to do this in collaboration. So having that system-wide approach with practice and policy and researchers working together and having that coordinated effort across stakeholders. For those who'd like more information, I've got a couple of QR codes there. One is for the My Baby Now app if you'd like to have a look at that. And there's a QR code there for registering for the training if you're interested in doing that, our website and our email address. So we'd love to have conversations with anyone in the room who's interested in implementing infant or indeed doing training or other aspects of nutrition in the first 2,000 days. Thank you.